Not at this time. The studies that were done and the approval from the FDA currently is for patients who have at least first relapse. Okay. So in patients who are already in remission, we would not recommend adding it at this time. We just don't know if it's going to add any benefit at this point.
Very good. Yeah. Thank you.
Long survival can be achieved with treatment, even if you did not achieve a complete remission. Dr. Bhutani mentioned that. The goal to achieve a complete remission and minimal residual disease negative is used as a surrogate marker for those patients who have lived the longest, based on studies in many clinical trials. In general, those patients who have less disease will live longer. But there are certain biological exceptions to tell something that is sometimes patients who go into complete remission extremely fast, and those paradoxically are those who recur faster too. And then you have patients who never achieve a complete remission and go into a partial remission or very good partial, and they stay in this stationary state, in a dormant, sort of smoldering stage for years. So it all depends on the biology of the disease that is left behind, or the cytogenetics and other aspects of the patient.
Just one comment. Minimal residual disease negativity has shown to be, or to have a better outcome, and it's the goal. There's no question. But I completely agree with Dr. Niesvizky. We all share patients who have a little bit of an M spike, and they do very well with this little bit of an M spike. And I remember one patient during my time in Pittsburgh. She was 18 years out of transplant with her little MGUS, and she was doing very well. So when patients are very disappointed that they didn't go into the MRD negativity, I always say, it doesn't necessarily mean that you do worse with this. You know, it's an individual case. And Paul Richardson mentioned that during our last debate meeting. He made a very nice comment. He said, maybe it's kind of that there's an auto-vaccination, so that the little amount of your myeloma gives you kind of, induces an immune response, and that constantly the body tries to respond to that little baseline M spike and produces, I would say, antibody against that. I found that a provocative hypothesis, but it makes sense biologically, because how do we explain that patients with residual myeloma do so well? Patients with residual breast cancer do not do well. Usually that tumor grows, and myeloma, it's kind of, they go back to MGUS, and it's kind of, over years and decades doing well. Yeah, maybe I start. I have the microphone. It's an excellent question. The short answer is yes, I do use triplets, especially in the first relapse. The long answer is it depends on the patient. So let's say you have a young patient and the patient has the first relapse. I would do everything to bring that patient in another deep remission. So yes, I would use a triplet, daratumumab, pomalidomide, and dexamethasone. I would try to avoid drugs the patient had before, and because those drugs probably did not kind of achieve a remission that was deep enough. Though you have to say, if the remission was 10 years, then you can go back. But if the remission was only 2 months, then probably really switch. So tendency, triplets, yes. Can try to change treatments. I think daratumumab would be my first choice. It's not allowed in the first kind of line, but for the first relapse. If the patient is 92 years and tells me, doctor, I don't want to come, for your injections, I would really not even consider a triplet. I would use, a doublet, a low dose of steroids, and a pill that is very well tolerated, for instance, ixazomib. So it really depends on the patient. And this is where you need a discussion with your doctor and with a patient. What is your goal of treatment? Obviously, with a relapse situation, it's harder and harder to induce long-term remissions. But what is the goal of the treatment?
I completely agree, and the only thing I will echo is that we don't compromise patient benefit to leave bullets for for the later. The situation of the here and now is fundamental. So once we have, say, achieved a second remission or partial or very good partial or even complete in the second line or third line, then we can start thinking of cooling therapy, just going to maintenance again. But if my bias in the first line is continuous therapy, it's even more intense in the second therapy, and always trying to achieve the best benefit. But of course, depends on each patient.
I agree completely that you know the goal or the benchmark has to be what we call an overall survival. Obviously, as I showed, you can get the patient in deeper remission. The remission rates are higher, and it clearly is seen that with the deeper remission or the triplet therapy, the duration of remission is longer as well than just using a doublet. And more, I think as the data matures, we're also seeing now an improvement in overall survival with triplets at relapse. So I think that is, pushing us more and more towards triplets. Plus, with daratumumab being so well tolerated, practically, very, very little side effects, I tend to use that very commonly with triplets.
The question was that what's the value of MRD evaluation for a patient once it's established, or what's the treatment in the future of a patient who's MRD negative, and we don't know yet. It's the MRD field is moving very fast, and as I said in the talk, there are techniques, and there is a lot of problems of standardization, and so not everybody's MRD is the same. So when you're evaluating MRD, you have to go to the gritty-nitty and see exactly what's the features of that test. That being said, it is very important to establish in the future whether MRD negativity will predict long-term outcomes with maintenance or without maintenance, with transplant or without transplant. These type of predictions are being evaluated right now. So we will know the answer, but right now we don't have the answer.
Again, I agree. I have to say, MRD research is important. We want to know who are the patients who are cured. Is achieving MRD negativity a precondition to be cured? So those are important questions, but I was not happy about the dynamic of the MRD discussion, to be very honest. I could see that patient support groups and talks were filled with MRD over and over. Patients got very confused. They came to me and they said, can you do MRD testing? And you don't want to, we are academic doctors. We enjoy research, but we don't want to be negative and give the impression that we do something which might be important for the patients, and we kind of, don't do it for the patient. But we have very smart patients. And I had just recently a patient, I suggested MRD, and the patient asked me, would it change your approach? And I said, no. And the patient said, what's the point? And we both agreed completely, and we didn't do it. And it saved the bone marrow. And I think the research is important. I recommend, if we do clinical trials, I recommend everybody should participate in clinical trial. Everything we know and what we presented is from clinical trials, and each of you helped to kind of, to get this knowledge. I think we should do MRD testing within clinical trials, but if you ask me, I'm MRD negative, can I stop maintenance? I don't know. Or I'm MRD positive, do I need to increase my maintenance? Should I do a doublet maintenance instead of kind of, one drug? Exactly, don't know, those are difficult questions. If you want to have it, tell your doctor, but if you don't have it, I think that's okay.
One of the haters for this.
Let me just
He said
patient spoken 2-3 years ago. He said it's not standardized, and
a week ago, a patient, a young patient, in his 50s, who's been in remission, good remission for about 10 years. He, and it's a real remission. He said, can I have MRD done? And I said, why? Because I want to know, he said. So what would you answer to that patient?
That was a rhetorical question.
Any other reason to do the bone marrow biopsy? No, then I wouldn't do it. I mean, bone marrow biopsy has a risk. And you always, so if you as a doctor do a procedure, you always have to ask yourself that would the procedure have a consequence? And in case not, then you better don't do it, because if you have a side effect from the procedure, an infection or bleeding, or you hit the nerve during the bone marrow biopsy, I think you have to justify, why you did this. Dr. Bhutani?
Yeah, I agree. I think we don't know what to do at this point for patients who are MRD negative or positive, and I think we have to learn more. I think one thing that I would like to say that from this data that we have seen, a large majority of the patients with MRD negativity also still continue to relapse. So it's not, as far as we have seen yet, it does not seem to predict cure at this point. Although it definitely helps to predict a longer remission. So that's actually, is a typical, what we call a relapse actually. Many patients who start out low risk, tend to have high risk at relapse. Although, as I said, about 15% of those patients are high risk at diagnosis. At first relapse, that number goes up to 30 to 40%. At second relapse, that number goes even higher. So that does happen over time because, as Dr. Niesvizky said, one myeloma patient has maybe 9 or 10 clones in there, and one of those clones could be high risk. And at relapse, that clone is most likely going to grow.
Yeah, you wipe out the sensitive, the low-risk clones with a chemo, and the bad cells survive, and they give probably rise to the next relapse. Any comments?
Yeah, there is additional mutations that happen. As I said, starts with 5,000. In relapse, you're over 20,000 mutations shared. So it is a very plastic, ongoing, heterogeneous disease. Well, just recently, about 3 or 4 years, the nature of the relapse was evaluated in patients who were originally had an intact immunoglobulin. Let's say the patient was IgG kappa or IgG lambda or IgA kappa or lambda, and they were fine. And when they relapse again with IgA kappa or with the original. Whereas other patients were originally IgG kappa, and now they relapse, they're just light chain, what we call the light chain escape. Those patients do have a worse risk in that sense. So yeah, there are certain features of the relapse that can tell you it changes. If the relapse is extramedullary disease, a mass that appears elsewhere in the body, in the viscera or somewhere, that also would yield worse prognosis.
The problem is, even if we identify high risk and we know exactly the mutation, we don't know exactly what we do with it. So we are very rough. I mean, everybody gets RVD or KRD, so we know a little bit. We know exactly when you have high risk, you should receive a proteasome inhibitor. That's important. Proteasome inhibitors do patients who receive proteasome inhibitors do better when they have high risk disease. And we know recently we had a drug, venetoclax, that showed high responsive or higher response rates in patients with 11-14 translocation, but the data are very, very limited. And venetoclax is not approved for multiple myeloma. It's only available in clinical trials. So just that even if we do all the testing and we have the mutation, we have very limited tools to directly treat the mutation. It's not that you have a certain mutation and we have drug A and treat this. It's not like this. Maybe we will come there and we're in a phase where we collect a lot of data and compare later who is doing better with which combination. But right now there is limited effect. So even if we see there's high risk, probably the result will be, okay, we give a proteasome inhibitor in addition.
So I think high-risk disease, has remained a challenge that we have not solved yet. We have gone made tremendous progress in low risk, or what we call a standard risk disease. And correct me if I'm wrong, Dr. Niesvizky and Dr. Lentzsch, but I think there is some preliminary data now that the immunotherapy might be helpful in overcoming that it might act independent of the risk of the cancer. And there is some initial data from the studies that were done with daratumumab, is that the combination worked as good as in intermediate and high risk patients. And we'll know as we go along. It's preliminary, and maybe the CAR T cells will help in that. But I think it's still preliminary.
So to answer your second question, which is the low-hanging fruit, I would say yes. The high risk identifies people with low PFS and low overall survival by virtue of their genetics, or by virtue of their biology, or by virtue of their kidney function, or the number of the relapse. There are so many aspects of the host, of the myeloma, of the psychosocial situation. There's so many things that can make you high risk. In general, for clinical trials, we're using high risk as a term for the genetic and the beta microglobulin and the biological features. But there is also some clinical features that make you high risk, and those have to be identified. If we can stay a couple of hours to speak about biopsy. So clarithromycin is the name of the antibiotic. Biopsy is the generic name. We have found that augments responses, and in fact, the 50% complete response that VRD has shown by Dr. Bhutani is equally found when you use the clarithromycin, the biopsy, with lenalidomide and dexamethasone, and we have replicated those results in the relapse setting with pomalidomide and dexamethasone, and with other combinations. The field has been critical of this data because there was no randomized data. Mayo Clinic actually took their database and asked for our database so they can blindly evaluate it in a case control study, and the clarithromycin arm was superior in PFS and overall survival. So that's fundaments to do a randomized trial. So the randomized trial is ongoing. So to give you the results of a randomized trial that compares lenalidomide dexamethasone versus clarithromycin, lenalidomide, and dexamethasone is being run right now. So we will get that answer. Well, let's just start by saying that a patient with MGUS is not MGUS until you don't do a biopsy. Certainly there are 80-year-old patients who come with a monoclonal gammopathy, which is that little spike in the blood, but has no other clinical data. So those patients, we might not go through a biopsy. And there's some characteristics, clinical characteristics, that we can choose to do biopsy or not. But strictly to define MGUS, monoclonal gammopathy for indeterminate significance, you require imaging, which is what Dr. Lentzsch spoke about, and a bone marrow biopsy. Let's say there are certain insurance carriers here that can still give us troubles to do what we consider standard of care. And they would do the x-rays that you have, but also it's necessary to do the bone marrow. Yeah, we would do it as an initial assessment, and then from then on to decide whether you need treatment or not. That would depend on whether you have MGUS, or you have smoldering, or high risk smoldering, or actually active. Yeah, but that's why you require the whole picture to be evaluated. Now, I wouldn't worry about transplant, because transplant is just a tool, and we have now 15 tools. So just think about availability of transplant as a tool.
The question to do a bone marrow biopsy in MGUS, yes or no, is discussed. Usually I have the tendency to do that, to have a baseline. If I have a patient who comes from has by accident an M spike that is maybe not even measurable, very low, and the patient has absolutely no other symptoms, no anemia, nothing else, I sometimes skip the bone marrow and I just continue to watch the patient. But if you have any doubts, bone marrow, yes, and then imaging, just also to have clarity what is going on. Imaging, at least a full body skeletal survey, usually the toes and the lower extremities, that means below the knee, are not included, or the hands in the skeletal survey, except your Little Rock, Arkansas. I think they do the hands in their skeletal survey. We usually x-ray the long bones where you have bone marrow. Yeah, the myeloma sits in the bone marrow and attacks all the bones that have bone marrow. I would ask for a PET CT. You are young, 65. What I would not do is to do the bone marrow transplant or the stem cell transplant to say, oh, I want to do that before 70 because otherwise I might not get it. You might be happy with your MGUS or your smoldering myeloma the next 20 years and might never need a transplant. So don't push for it.
So that's a very good question. Over time, we have identified a group, what we call not all smoldering myeloma, but what we call a high-risk smoldering myeloma. So a subgroup of patients with smoldering myeloma, based on their disease burden and sometimes based on their biology, have a very, very high risk of progressing to multiple myeloma. And the research right now is focusing whether if we treat those people earlier, can we improve their long-term outcomes? We're still in the research phase, and although there has been some data, the data was very preliminary, but the field is moving towards that to catch those patients earlier. As you said, it's only in the clinical trial phase, so we will only know once the data comes out. Some physicians, have raised this concern, as you raised, whether are you going to make myeloma more resistant by treating it earlier when it relapses? But we don't know that at this point, unfortunately.
So it's a cycle of getting into the disease process.
Yes. Yes.
Just one comment. I wouldn't treat smoldering myeloma outside of clinical trials, to be very honest. Maybe high-risk smoldering myeloma in very young patients. We have a discussion among doctors that if you do this and you don't know for sure that it will prolong life, you should be really careful, consider your actions, because it would make a lot of patients who are happily living with their smoldering multiple myeloma sick patients getting a stem cell transplant and getting intensive treatment. And even if you say the treatments are well tolerated, there's no treatment without side effects. So I'm not sure whether we should really kind of do this or consider this outside of clinical trials.
Absolutely agree. High-risk smoldering, even the statistics tells you that they may have progression within 3 years. I still am uncomfortable to offering treatment to those patients with high-risk smoldering in that category without a clinical trial. We have clinical trials open, and we offer the clinical trial, including similar trials with carfilzomib, lenalidomide, dexamethasone, and transplant, and the whole thing, just to try to achieve a cure. But it's a phase 2 trial, so we don't even know what that's going to give us. We still have to do the phase 3, and so right now we cannot recommend. Let me step a little bit up. Dr. Lentzsch told us that now the definition of myeloma changed. She told us that now we don't need the CRAB criteria to define myeloma. Now we need some biomarkers of malignancy, such a high light chain of about 100. And if we have that, we should start treatment. And I have begun treatment. However, I have one patient that has been with me for 10 years, so he was not aware, and I was not aware of these new criteria for 10 years. And now that we are 10 years after, I had to tell him, well, there's new criteria, so I need to treat you. He said, I'm not getting treated. and his light chains are 100, and he's been perfectly fine. So it's still individualized decision in terms of treatment.
In terms of the trials, I don't find as opposed to not high risk, as in taking the people into the trials?
I think most of the trials are looking at the specific criteria, not taking every smoldering myeloma, but taking only a subgroup of smoldering.
Remember, smoldering myeloma can be you have 11% plasma cells and very low M spikes. So those patients would not qualify. That's for sure. You know, So for high-risk smoldering multiple myeloma, for instance, if I remember correctly, the free light chain ratios should be 18. You have certain cytogenetics. You have an IgA multiple myeloma, for instance, would also qualify for a higher risk. There are kind of, if other criteria, Ruby, help me out, chemo brain.
No, no, but also is the depression of the uninvolved immunoglobulin is the number of percentage of the cells, and the first classification that talking about higher risk smoldering was talking about more than 4 grams of the M protein, but that's no longer part of the definition.
So, I tell my patients, that they can eat anything they like. I don't recommend anything specific, but I, do encourage them to avoid foods like fast foods, McDonald's, French fries, and stuff like that. That's gonna, maybe give you like a boost of energy when you eat it, but then it's gonna make you very tired afterwards. So avoid foods like that, especially that are going to slow you down afterwards. So those are the things I recommend to my patients. Otherwise, they can eat more or less anything they like. Yeah.
Just one comment. I know how difficult it is to get the diagnosis of a cancer and that the patient wants to do something to help. And we often hear the question of, what can I do? Can I take any supplements that would really help or fight the cancer? Antioxidants? What is it about? I can just kind of, really warn you, don't spend too much money on this. People go out and promise you a lot. If you would know how many millions we spend on research and how many billions of dollars are into that research, if somebody could really prove that antioxidants would fight cancer and prolong life by 10 years, I'm sure companies would do those studies and would invest the monies. But they can't show this. They don't have the data. They just go out and try to catch you with what they promise, and they know nobody would go and sue them and say, my cancer didn't respond and I paid $4,000 on this. Just make sure how you spend your money, use it really wisely. I feel so sorry when I see that sometimes patients come back and say, I bought for $2,000 this and this and I believe in it. I know it's difficult, but again, there is no cancer diet that really prolongs life that has been scientifically proven. To Mary.
There is a lot of zealotry and fundamentalism in terms of diets, and supplements for diets. The first thing I would say that the stories that you hear about myeloma requiring glucose to grow, so I'm going to stop eating glucose, does not make sense. And you should not refrain of eating a fruit because the fruit is sugar, and the myeloma is not going to grow faster or slower because you stop eating fruits. I saw on a website, a very famous myeloma, reputable website, that you shouldn't be taking Valencia oranges. And I really had problems because I like Valencia oranges. There's some things about grapefruits. For instance, in grapefruit juice, there is well-known interactions, pharmacological interactions, that's why it's avoided. There was some say, and still is not clear whether green tea can reduce the response to chemo. So it's best that you Go over your diet and your supplements with your doctor, and you're fully transparent on your supplements with your doctor about specifically what you should be taking. Very careful with this alkalinization story. I keep on hearing that I need to be alkalinized, so the cancer does not grow, and that is even from very reputable nutritional specialists. And I tell you, those people didn't study physiology in basic school, because the body has a very tight regulation of the pH, 7.4, and if you go to 2 points one way or the other, you die. So there's no way that you're eating kale, you're gonna get alkalinized.
Right. NSAIDs, that's very important. We know especially myeloma kidneys are very sensitive. Avoid all kidney toxic substances. Dr. Niesvizky has
Well, when you,
specific recommendations.
we always tell the patient that whenever you're going to have an IV contrast through the X-rays, you tell you're allergic. There's specific things IV contrast that you can take. The gadolinium for the MRI you can take. The sugar-based dye for the PET scan you can take. But there is iodine-based dyes that they use for certain types of X-rays that you should, in general, avoid. If there is a life or death situation in which they have to check your heart or your lungs, let the team speak to your doctor about what can you do to avoid the kidney damage with that. There are certain antibiotics that are seldom used, we call aminoglucosides, that can also damage the kidney. So everything has to be done under supervision of your doctor.
We had
So-
actually
so-
a
so
patient
do they-
recently
do
we
they do-
discussed. The patient came to Dr. Lentzsch and asked to discuss if, she's MRD negative after the induction chemotherapy and whether she needs the transplant at this time or not. And clearly, we don't have the data to suggest that, but what we do know in some of those studies that the purpose of the transplant is not just to push the disease down, but also to keep it in remission for longer time. And from the data that we have, it still looks like the transplant does help to keep it in longer remission and maybe in some studies also improve the survival. But we still have to sort it out. I don't think we have the perfect answer at this time, but we continue to recommend it in those cases.
I think the reason is we don't have enough data to show us that it's safe to skip transplant. Yeah? So all the data, what you showed, what Dr. Bhutani showed, was patients with transplant have a longer progression-free survival, and so far, I would say, data we have so far in comparison, a longer overall survival. Those patients include patients who are MRD negative. There's no sub-study that would show kind of who especially benefits from it. And when I talk to the patient, and again, we had those patients, we discuss it very open. And it's a difficult situation for the patient, and I know that our patient got opinions, second, third, fourth, fifth opinions from everywhere, but finally made a decision to move. It was a decision of the patient to move forward. I would recommend to have a transplant. MRD negativity is just one piece. It might be a bone marrow that hit the wrong spot, maybe 5 centimeters next to it, you would have MRD positivity. We don't know whether our methods are 100%. MRD by flow and by next generation is, I would say, more sensitive than the blood work, immunofixation. But is it sensitive enough to really give 100% assurance there's no disease left? So I think that's why we would say until we know better, we still recommend transplant to eradicate residual disease. Dr. Niesvizky is not doing transplant, right? That is our opinion.
I'm so glad that you brought up, because now there is a debate. I respectfully disagree. And you're going to find that disagreement. The bottom line, it's a decision that the patient and the doctor together. The way I see it is for the randomized trial for transplant early versus late, there is no inadequate. There's one piece of the data. The other piece of the data is that when we looked at our clarithromycin data, the patients who maintained on lenalidomide and clarithromycin did exactly the same as the transplant patient. And our belief is that until demonstrated otherwise, there is no survival advantage for early transplant, even single or double. So we tend to try to get to complete remission by first line as possible, and then harvest stem cells in the majority of the patients, and be ready for transplant in a delayed fashion. But we will move for maintenance in that MRD positive, MRD negative patient. If it's MRD positive, then we recommend